So universal healthcare, we have been talking since yesterday. I think many of you already probably know about this. Perhaps some of you know quite a bit about it. So I was not sure, and we don't have much time. So I will just quickly go through some broad outlines, educating ourselves and our colleagues and our other friends about UHC is a task which we need to take ahead. So this will just be like a small appetizer. And if you don't have a strategy, you're part of something else. So boss, अपना strategy होना चाहिए. कोई confusion नहीं है. अगर अपना strategy नहीं है, तो हम corporate sector की strategy के कहीं ना कहीं हिस्सा बन के रह जाएंगे. We have to have our own. And our strategy has to be to develop UHC. What is UHC? It's a system of healthcare which provides the entire population of the country a good quality health services according to people's needs. Everybody has access to the full range of healthcare regardless of income, social status, and it is free at the point when services are provided. So everybody has basically a right to good quality healthcare. And this is not a dream. In case आपको ये लग रहा होगा कि ये तो कुछ बहुत ही unrealistic सी चीज़ है. Many countries in the world have achieved a reasonably good level of UHC, and even India can move in that direction. Under UHC, it will be right to healthcare for all, no exclusions, no targeting, and even Mukesh Ambani will be welcome to visit the UHC facility. If he doesn't want to come, that's his business, but he will be taxed.
And so, no cards. No cards of any kind.
No cards. No cards. Anybody who walks in will get care, and everybody is welcome to get the services. So when the middle class becomes everybody. But the point is that there is no exclusion of any kind. Everybody can get free care at the point of service, and the elimination of unnecessary medicines, investigations, operations, procedures. This will cause a huge cost saving. Abhi, a lot of care that is going on, including medicines and everything, is wasteful. So actually UHC will bring down the costs of care significantly and eliminate irrationality or significantly curb it. Over medicalization will go out of the window. So right now, the hysterectomies, the cesarean sections, the unnecessary angioplasties, the MRI scans, all these things can get curbed. Uniform norms for urban and rural areas, and integrated care from primary to tertiary levels. And that is another interesting point which actually I learned from Kerala. In Kerala, the differentiation between urban and rural areas is much less. If you have visited Kerala, you'll find this. So this is not something which is totally unrealistic. And with good quality communication and transport, we can bridge that gap. And so that gap gets reduced. And of course, reducing ill health through integrated action on health factors and participatory governance at all levels. So what does UHC do? What is it? How is it different? So I mean, yesterday I went on a website on universal healthcare. उसमें एक list of countries दिया था. उसमें इंडिया का नाम भी था. Because I think a Wikipedia page है. मैंने कहा ये क्या लिखा हो? So see, the point is that universal healthcare is not just putting in place some public health facilities and saying, okay, जिसको जाना जाओ और जो करना है करो. That is not sufficient. Actually, what we mean by UHC is it brings together public, private, and charitable, all types of providers under a single system. So we are pooling all the healthcare resources which are there in society, or at least a large proportion of that. Maybe some big corporate hospitals may stay out of UHC. That is possible. But maximum number of providers are being brought in. It is publicly managed, publicly funded, and essentially through taxation. There may be a small component of social health insurance like ESI, which may also be brought in. Employers may pay for their employees that kind of thing. And it can rejuvenate the public health system, transform the private health sector, and ensure equitable care to the entire population. Many countries, so as I said, this is not a dream. If it is a dream, it's a realistic dream. At least, it's not something which is a pipe dream. So, besides UK, France, Germany, Netherlands, Scandinavian countries, Canada, Australia, all of which have in the last 50, 60 years developed UHC systems. We also have Thailand, Brazil, Sri Lanka, which are developing countries. There are many more. USA is a very good bad example of what should not be done. That's why I mentioned SICO yesterday. So once you go around the commercial insurance route, you land up in a huge mess. and that is the US. I don't have time to talk about it, but that just to alert you that is not. And now I will briefly take a short this thing about universal health care versus universal health coverage, because this is an area of major confusion and where perhaps we need some clarity. Health care is not the same as health coverage. Health coverage is essentially a financial mechanism. Health care is a mechanism which ensures actual availability and access to care. So it is one thing. So health card और health care में एक अक्षर का फर्क है. Health card is not health care, and I'll come to that. It's an important distinction, because today, like on many other fronts, the government is, well, I will use the word fooling people by saying कि आपको हमने एक कार्ड दिया है, बस इससे आपका काम हो जाएगा, और लोग भी सोच रहे हैं कि यार कुछ तो मिल रहा है, But this is not universal health care. It is something which we need to be clear about. So what usually happens in what is called coverage? The unregulated, unreformed, commercialized private medical sector without regulation of quality, cost, etc., which is prone to doing irrational care, that is as such brought into the coverage system. So it's like bringing a tiger into a room full of goats and saying कि आप सब लोग आपस में शांति से रहो. Is it going to happen? It's not going to happen, because that is unreformed. The private sector has to be reformed and simultaneously brought into the UHC system, and that is very important. Its irrationalities, its all kinds of features which are there right now, they have to be curbed. So if the private sector is involved in universal health coverage without regulation and reform, then we have spiraling costs, continued irrationality, soaking up of public funds. So like in the Arogyashri initial phase, thousands of women underwent hysterectomies. There are districts in Andhra Pradesh and Telangana where above 30 there's no uterus. So these kind of things started happening. Cochlear implants, all kinds of peculiar things happening. So if you just hand over funds to the existing private sector without rationalizing it, without regulating it, it will be, it is not a direction to move. And therefore, universal health coverage versus universal health care. Under coverage, there is weak regulation. There is lack of comprehensive rationalization of practices. Also, under universal health coverage, it's a one-size-fits-all. So there is no differential approach, for example, for insourcing charitable providers on a priority basis and supporting them and including them in the system. Corporates are likely to dominate that kind of system because they have greater clout. And somebody was saying like, yeah, the corporates are regulating the government. So that kind of direction is there is a threat of that. Private sector is brought in to replace public functions rather than complement public systems. Private sector should not replace public functions. That is very dangerous. It should complement. Commercial insurance is a big profiteering additional entity. एक तो private hospitals का profiteering है, फिर आपने commercial insurance को भी उसमें जोड़ दिया. So now you have two profiteering entities in the system. Both are going to take their cut. They are not going to go without their, their pound of flesh. And very weak accountability. Market failure basically continues. Whereas when we talk about universal health care, we are talking about effective regulation of the private sector, a differential approach, partial socialization of amenable private providers, and there is a struggle. If you know, in countries like UK or Canada or Australia, when their NHS systems were introduced, there was a struggle. A section of doctors, so for example in UK, the young doctors were in favor of UHC. The senior Harley Street, जो वहाँ का consultants, the top consultants, they were dead opposed to UHC because they thought it's going to, threaten their elite status. And there's a big churning, and finally, of course, 80% of doctors came on board. And even the rest ultimately didn't come. Canada, Australia also, there were strikes, so on. But younger doctors, doctors who had some sort of a more ethical and charitable orientation, they came onto UHC on board much earlier and much more ready. So we need to take a little differential approach and reach out to different sections. Private should complement the public but not replace the public. There are certain core public functions which must remain with public systems, and the regulatory capacity has to be increased, and it also has to be accountable. ये दोनों चीजें important है, otherwise corruption is also a big problem in our country. So that is why, for example, the Brazilian health councils or the Thai health assemblies, ये पूरा UHC system जो है ना, this has to also be held accountable by ordinary people. Otherwise, there is a risk that funds will flow from the government coffers into the private sector in ways which are not actually benefiting ordinary people. So this is a big topic. And of course, whenever I take this kind of a session, the first question I'm asked कि ये आयुष्मान भारत क्या चीज़ है? उसके बारे में आपका क्या स्टैंड है? आयुष्मान भारत is actually not even universal. It is some kind of health coverage. Okay, so it is some kind of health coverage for some part of the population. It covers about 40% of the Indian population, whereas UHC will cover everybody. PMJY actually. PMJY doesn't provide outpatient care, which is 70% of the expenditure. So huge area completely left out. UHC will be integrating outpatient and inpatient care. PMJY focuses on certain operations and procedures, not even conditions. So it's not even that if you're a diabetic, everything will be taken care of. ऐसा भी नहीं है. अगर diabetic foot है, तो amputation हो सकता है. Yeah, I mean there are certain procedures, 1350 procedures which are identified. उस procedure में अगर आप बैठोगे, तो वो आपको मिल सकता है. वो भी सब जगह नहीं मिलेगा. Hospitals also do cherry picking जैसे ये हमारे or whatever. Even in a best case scenario, it is not treating a patient or a condition of a patient. It is offering a procedure, and there is an important difference which And in a UHC system, actually screening of patients, trying to treat patients at primary and secondary levels wherever possible, and only selective patients who really require tertiary care will go to that level. यहाँ उल्टा हो रहा है, patients will be pushed into a tertiary scenario, because that is the only thing that is available free. And the experience in the last 15-20 years in India is that such insurance schemes do not reduce out-of-pocket expenditures significantly. There are about 15 studies and a meta-analysis which has been done by Prinja and others. Prinja is from PGI Chandigarh. A very good analysis which shows that in almost all these schemes there was no major reduction in out-of-pocket expenditure. Whereas UHC has to be free. I mean, it's basically that's the whole objective. So health card is not healthcare. Insourcing of private providers is very different from what we call PPPs. यहाँ partnership का चक्कर नहीं है. यहाँ public system है. It's a publicly organized system, and private providers need to be involved in this system. So it's a different kind of arrangement. And I mean, so what would be the way in which individual practitioners, small hospitals, charitable hospitals, how would they be involved in the UHC system? This is something which requires more discussion, but the whole idea is like in NHS. If you probably know what NHS is like, there are individual practitioners. They have a contract with the NHS system. So technically they remain private, but practically they have become like public. That is actually the kind of what I'm calling partial socialization. So they have an annual contract. Theoretically they are free to practice on their own if they want, but in practice they all basically regularly become part of that system. Similarly, smaller private hospitals, nursing homes, etc., they could be either completely insourced, you are part of the UHC system, like I've seen the system in Brazil. Thailand also has something like this. So either you're completely insourced, your entire hospital only caters to the national health system, or it's partially insourced. So you can have somewhere 1/3 of the patients you can treat, but the majority of patients will be your beds are reserved for the UHC system. And that is the kind of direction of progressive socialization. Now I'm not going into this, how do we move from the existing insurance schemes to UHC? This is an interesting topic, but if we don't have much time, I'll just skip this. But the point is, it is possible to have such a trajectory. And if there's a political will, ये जितने PMJY, MPJY, ROKShree, RSB, ये जितने हैं ना सब, all these alphabets, it can be configured in a way, remove the commercial insurance company, generalize the benefits, make it universal, and steer it in a direction where it merges with the UHC system. So people will not lose entitlements. कभी-कभी लोग कहते हैं आप तो PMJY के खिलाफ हो, तो हम बोलते हैं हम PMJY के खिलाफ तो हैं, लेकिन हम इसको we will replace it with something much better. It's not that we are taking away, we are asking something to be taken away from people, we are asking something much better. क्योंकि इंसान कभी कुछ छोड़ता नहीं, वो नया पकड़ता है. And we'll have to keep that in mind when we, predict the insurance scheme that we have to give the alternative. Now, this is a biological model which I use. How do private providers become part of the UHC system? There are two different models. So I call these the virus model and the mitochondria model. Do you know how mitochondria came into existence in the evolutionary pathway?
It is supposed to be an archaebacteria which got involved in the cell. So it gave energy and it got heat.
Exactly. Archaebacteria, actually a few billion years ago, mitochondria have their own DNA. Do you know this?
Yes.
They replicate on their own. They are almost like autonomous entities within the cell, and only eukaryotes have them. So billions of years ago, bacteria entered into certain animal cells, and they developed a symbiotic relationship. So mitochondria are actually autonomous, but they have become part of our cells, and they provide energy to our cells now today. That is one model, and the other model is the virus model. वायरस मॉडल में क्या होता है? वायरस आता है, सेल में अपने को इंजेक्ट करता है, रेप्लिकेट करता है और सेल को खत्म कर देता है. This is one model. And the mitochondria model is the bacterium enters. This is of course over billions of years of evolution. It has entered the cell. It has become part of the cell, and now it is actually behaving as a part of the cell. So it is the mitochondria model of incorporation of private providers into the UHC system, which will energize the system but not disrupt the system. This is a crux, and this is something which we can discuss much more. इसमें बहुत सारे nuances or details हैं, but I think this is very important. That is the difference between universal health coverage and universal health care. Another big question is, do we have the money? क्योंकि पहली बार तो लोग कहते हैं ये पॉसिबल नहीं, दूसरा कहते हैं अरे है तो पॉसिबल लेकिन इसमें बहुत पैसा लगेगा. Both actually, so Thailand and Brazil, they have 3.7% and 4.7% of the GDP. Thailand is probably closest to the Indian situation in some ways. So 3.7% of the GDP is not an astronomical amount, because we have already committed 2.5% of the GDP under the national health policy, and these are realistic goals if there is a political will. Many states in our country, incidentally, like Mizoram and Goa, do spend out of their their state domestic product a substantial amount on healthcare today even. So we need to upscale. It is realistic. And the second thing is eliminating wasteful procedures, unnecessary medications, unnecessary operations. All these things will make UHC much more viable. Achieving UHC in the next 5 to 10 years is a viable goal. And the interesting point is nobody will oppose UHC. But UHC is actually a politically attractive agenda. Even political parties would be interested. It will give them popularity. And you'll say, boss, karo aap. Janta ka fayda hoga, aapka fayda hoga. Or of course, healthcare providers will also. What will UHC offer to doctors and healthcare providers? Including smaller hospitals, charitable hospitals, and so on. Today, the entire environment is so competitive, profit-driven, and commercialized that it is distorting the quality. So like we call it the quality of life, we should start talking about the quality of practice. आप practice कर रहे हो, आपके practice का quality. Does your practice give you satisfaction, or does your practice give you stress? So if you look at the quality of practice in a UHC system, the quality of practice would be much better. Of course, at the same time, it would provide security, because then you have a secure contract. You don't have to keep thinking, कल patient आएगा कि नहीं आएगा, ये patient मेरे यहाँ admit होना चाहिए, तभी मुझे उसका पैसा मिलेगा. All these things go out of your mind. You are part of a system. You have a certain kind of security. You don't have to compete with others in a cutthroat manner. And if you look at doctors who work in UHC systems in France or UK or Canada or Australia, they earn reasonably well. But it's not like minting money. Minting money is out. That kind of super profiteering is out, but you can have a decent income for doctors and other healthcare providers, elimination of all these. And of course, this insecurity, which yesterday somebody was talking about. कि कब आपको निकाल दिया जाएगा कॉर्पोरेट हॉस्पिटल्स में, आप कुछ बोल नहीं सकते हो. आपने जो बताया था वो कॉफी वाला एग्जाम्पल. So there's much greater degree, and human beings basically respond to their environment. Give them a bad environment and 90% will behave badly. Give them a good environment and 90% will behave well. This This is actually a historical fact. So UHC changes the game. It changes the environment. So then goodness becomes the norm instead of being the exception. And so then this is my other favorite slide, which you probably may have seen. So what does UHC do? In summary, and I am concluding now. Today this is the situation. Profit logic is dominant. The social logic is weak. It is there, but it is weak. So UHC just simply does that it involves the social logic prevailing over the profit logic. बड़ा पहलवान छोटा हो जाता है और छोटा पहलवान बड़ा हो जाता है. So that's it. So if somebody asks you what is UHC, this change is UHC. So it's not that profit will disappear. The private sector will remain, but the social logic through a publicly organized system will become dominant. The core barriers to UHC are not technical, they are not even financial, they are political. And history of many countries, you look at the history of Brazil or Thailand, how did they develop UHC? It was a political process, where usually they call it the triangle which moves the mountain, as a Thailand में एक ये है. So what is the triangle? There are three angles to the triangle which moves the mountain, which means which got UHC. A, social movements. B, healthcare professionals. C, political leaders. ये तीनों एक साथ आ गए, UHC हो गया. मतलब I'm putting it a little simplistically, but basically this is the way in which UHC systems have developed. So I'll conclude here. So somebody mentioned Norman Bethune, and so what Bethune said is medicine, as we are practicing it, is a luxury trade. We are selling bread at the price of jewels. Let us take the profit out of medicine and purify our profession of rapacious individualism. Let us say to the people not how much have you got, but how much can we serve you. So that is what you will see.